lecture, and I think it is also very important to us to advance our knowledge about, especially now about alloimmunization, not only in view of alloimmunization for erythrocyte, but also for neutrophil and also for platelet. Teman sahabat sekalian, rasanya ini menjadi satu tambahan ilmu yang sangat berharga bagi kita karena ternyata banyak sekali korelasinya yang dengan transfusi yang kita lakukan sehari-hari atau dengan penyiapan komponen yang kita lakukan sehari-hari, dan harus kita jujur bahwa kita masih sangat jauh ya, tapi bukan berarti menurunkan semangat kita, tetapi itu sebuah tantangan bagi kita bahwa pada saatnya kita juga harus mencapai tingkat-tingkatan seperti ini ya, sehingga apa yang bisa diberikan untuk pasien itu menjadi optimal, baik itu safety tetapi juga quality. Saya kira masih ada waktu untuk tanya jawab. Dipersilakan kepada teman sahabat sekalian yang Bapak Ibu yang ingin menyampaikan pertanyaan, dipersilakan. Mau bahasa Indonesia boleh, bahasa Inggris juga boleh ya, karena beliau juga tahu bahasa Indonesia. Nanti dibantu kami atau Dr. Usi, Dr. Umi nanti bisa membantu. Dipersilakan.
Apakah hasil dari CCI ini dapat membedakan refraktori dari imun maupun non imun, dan apakah ada angka dari keduanya yang berbeda? Kemudian yang kedua, untuk perhitungan CCI 1 jam pasca transfusi ini, apakah ada rentang waktu yang diperbolehkan, misalnya 1 sampai 4 jam, ataukah harus tepat 1 jam pasca transfusi? Kemudian yang ketiga, produk platelet concentrate leukocyte ini kan dipercaya dapat menurunkan efek samping seperti FNHTR ataupun trali. Tapi apakah ada mungkin dari pengalaman, apakah dapat memberikan nilai CCI yang lebih baik dibandingkan produk yang non leukocyte? Terima kasih.
It's a very, very important question. What I always do is when the hematologist is calling me, my patient is not reacting on platelets, I ask for, is there a diffuse interfacial clotting, intravascular clotting, or is there a how's the spleen? Is it a splenomegaly, or what is the kind of medication you're using? Do you have a bacterial problem, and how quickly your platelets are decreasing again after the transfusion? So I know a little bit about the clinical situation. I'm not a clinician, I'm also working in the blood transfusion service and not in the clinics. So, and we cover about 40-50 clinics, and in the night 108 clinics. So what you do see on this slide is that when you have this one or you have this one, then you will have once in 2 to 3 days you need a platelet transfusion. So after 2 to 3 days going to that way, your platelets will be below 10 again. But when you have such a situation, so after 1 hour it's still a little bit, it's not that high, but it's on the border. And after 24 hours there's nothing anymore. This is usually a non-immune refractoriness. But when you see after 1 hour the platelets or the CCI is already 2 or 3 or 4 or something like that, you have an immune refractoriness. So this is, after a few hours, it's gone again. So that's the discrimination you can do between immune and non-immune refractoriness.
Okay. The second question, Dr. Hans, is about we should or we may calculate the CCI at 1 hour post-transfusion. Is 1 hour is a strict time, or for instance, can we calculate it in, for instance, 1 to 4 hours post-transfusion? Yeah. So
this is the usually advice.
okay.
So it's not strictly. You can do it after 2 hours, or that's also possible too. But 3 hours, 4 hours, 5 hours, 6 hours, you can do it. But you should keep into mind that your CCI could be 0 again after 6 hours. That you know, or it's when it's 3 or 4 after 6 hours. The discrimination between an immune and a non-immune refractoriness can be very difficult. So you, when the CCI after 6 hours is, let's say, 12 or 10 or so, you know everything is okay. When it's below the 7.5, you should go more in your next transfusion, you should go more in detail and in a shorter time.
And the last question is about the leuko-reduced platelet concentrates can reduce the incidence of FNHDR. And is it also this component have a relationship, or can also increase the CCI result?
Oh, that's a difficult question. It will give less febrile reactions, but in a febrile reaction you can have some damage of the platelets. So in theory you will have, you could have a decrease or influence on your CCI with high leukocyte counts, in which apheresis products usually are already. So, but this increases the price also. In the PRP products, as you normally deliver, this is not possible by doing this by filtration or in another way. You have somewhat higher leukocyte counts than in the white blood, in the Buffyco-derived platelets, in the pooled platelets. But yeah, that remains very costly. So apheresis, when you have lower CCIs and you see transfusion reactions because of the leukocyte count, I would also go to apheresis platelets. It's in that way, it's a better product.
Thank you for the time. Maybe I try to tell in English. What the step explanation to the clinician if we found the platelet count is lower than before transfusion? Sometimes the clinician blame our lab because maybe they think what's wrong with our analyzer. The patient has been transfused even 10 units, but the platelet count is lower than before transfusion. So we recommended the patient to find the anti-LHA or anti-HPA or anti-NHA. After we exclude there is no bleeding, no enlargement of spleen, no fever. So what is the step of explanation to the clinician?
So indeed, you do already what I would do also, is talk to the clinician. Is there a splenomegaly, is there a bleeding, etc. And that's the same. So you try to exclude your non-immune cases of refractoriness. So the 1 in 5 chance that you have that are HLA or HPA antibodies remain. So it's very easy then, and usually the persons with refractoriness, immune refractoriness, are females, female patients, and the clinician will understand HLA antibodies. I hope that they will understand, but you should, and also counting on that you give a good product. So you gave sufficient platelets, sufficient working platelets, and when it's not, and it's ABO compatible, then it's not working and not increasing, but even 1 or 2 hours or 3 hours after your transfusion, the platelet count is even lower than before. You should explain that you need HLA compatible. So and this should be explained because of the antibody reaction in the patient.
Okay, thank you. But maybe in our lab, our hospital, to find the HLA compatible, it's difficult.
Yes, indeed. I know it's very difficult, but you could do cross-matching between. You have big families available, and you will see that when you could achieve, even from in the HLA system, you have huge. You can make use of a huge cross-reactivity. So you can have cross-reacting antigens. So of course this can work against your HLA system, but also can in favor. So even the brother of the father or the nephew could be of help because they are rather similar. So the son of your patient's brother could be of help. And I would explain this. It's against WHO, I know. But this is for you, for the time being, the only possibility to find HLA compatible donors. And when the fish family is big enough, you could do even cross-matching. So cross-matching and find the most agreeable donor. And when you have then in that time 1 or 2 or 3 sufficient donors, you can do apheresis twice a week. It's only for a short period. According to the international regulations, you're allowed to do 26 times an apheresis procedure to collect platelets per year, with a maximum of 2 per week, with a minimal interval of 48 hours, and 450 or 300 twice a week. And when you're really lucky, this donor has above 250 to 75,000. You can take a double component and store this on a flatbed shaker. You can store them for 7 days. So take them today, transfuse tomorrow, and transfuse after 3 days from the same donor. So you can be very, in a good way, working with your donor you have.
Okay, thank you very much. But maybe I actually never done the platelet cross-match. Is it the same with the red cell cross-match?
It's in the same system. it's a variation on this, and it's a kind of ELISA. It should be done in the lab, and it should be learned. It's not that difficult.
Maybe we can workshop for that. The platelet cross-match.
So you can take some blood from your donor prior to that, and take some serum from your patient, and then give it in a specific way. So you need a step in between to make a good connection. So what you do is, in fact, you cover your plate, your well of your ELISA with platelets, and add to that, you let incubate this with serum of the patient, and add an anti-human IgG with a color on it, a fluorescence on it, and then you can see it in the light. That's all what you do, in fact.
Correlation between anti-HLA and pregnancy. This process is similar with the process in research between differences between father and mother, and also how then this anti-HLA make or have the influence to the child or to the.
So it's taking a much longer time to achieve that, and usually the child is already born, so you don't see that influence on the child of the anti-HLA. But sometimes you do see, but you never measure it. You have, based on HLA, you have neutropenic child, neutropenic newborns. So it can have a severe neutropenia. Not that it has not that effect on the platelets, because the child is making sufficient platelets, so it's also neutralized by the other cells.
He or she already had anti-SPA, anti-human platelet antigen.
So when the donor has anti-HPA, so what you did see in one of the slides, about 22% has an anti-HLA, and 44% has an HLA and an HPA. So about 22% has also of the donors has anti-HPA. That's one thing. In Nigeria, that's one thing. When you transfuse this plasma, in fact, to your patient? That's the question, in fact, or not? So, yes, you will see a decrease of platelets. However, I think that there is a function of the platelets, but when you have a plasma transfusion, so sufficient plasma transfused to a patient with normal platelet counts, you will go from 250,000 to maybe to 200,000. So you don't see it, the effect that good. When you do this, of course, with a patient who has only 25,000, you could have problems indeed. Plasma is not given. So the question is more, when you do give platelets from female donors to your patient. So as you know that in the Western world, in the US and in Europe, female donors are not being used anymore for platelets because of the anti-HLA and the anti-HPA. So we count with that, but I think you don't have the possibilities to refrain of only female donors. Even we do not, in the HLA compatible donors, we do not count with the gender of the donor. So we use female donors for HLA typing, and we use them because otherwise you don't have enough. So in a normal situation, in a normal blood transfusion, I would put the female donor on the second place for the plasma and the platelets. But in an HLA or an HPA type situation, at least as high as. This is more to avoid TRALI.
Saya kira cukup mungkin ya, saya kira sudah cukup mungkin ya. Dan juga Dr. Hans, thank you, dan I will back to the Master of Ceremony. Applause to Dr. Hans again.
Our speaker today, we would like to give you a little gift from us, from the Faculty of Medicine, Universitas Gadjah Mada. Jaman. Rabbil Alamin, terima kasih atas partisipasi dari peserta dari kuliah tamu Continuing Medical Education hari ini dengan judul Allow Immunization Against Neutrophils and Platelet in Transfusion. Semoga menjadi tambahan ilmu bagi kita semua. Saya tutup acara pada siang hari ini. Selamat siang. Wassalamualaikum warahmatullahi wabarakatuh.